Good afternoon, everyone. After the coffee break, we are going to talk about molecular analysis in diagnosis and treatment of pancreatic lesions. I am Dr. Çisel Aydın, and I'm from Koç University. And during my presentation, first, we are going to talk about the overview of molecular testings, specimen requirements for molecular tests, and ancillary testings. And finally, I'm going to finish my presentation with summary. And molecular testings, including next-generation sequencing or immunohistochemistry, offers us critical insights into the genetic underpinning of both cystic and solid pancreatic lesions and helping us to decode their complex biology. This powerful tool enhances our ability to make precise diagnosis and provide tailored treatment options. And in the domain of pancreatobiliary disorders, our utilization of cytopathology samples plays a pivotal role in advanced diagnostics. By integrating immunohistochemistry and next-generation sequencing, we delve into the genetic landscape of diseases, particularly pinpointing germline mutations associated with pancreatic and bile duct cancer. And our techniques extend to identifying crucial somatic mutations and gene defects that drive personalized therapy, including those in mismatch repair genes and BRCA1 or BRCA2. And this strategic approach not only enhances our diagnostic accuracy, but also fosters tailored treatment plans and significantly improve patient management and outcomes in pancreatic diseases. And now, we are diving into the foundational elements of molecular pathology, focusing on the types of specimens we worked with, such as fine needle aspiration cytology or biopsy cyst fluids. And each type comes with its own set of technical requirements and primarily concerning the yield and quality of DNA or RNA and the fraction of tumor cells and presence, which are crucial for the accuracy of our test. However, obtaining and working with these specimens isn't without its challenges. The adequacy of a specimen can significantly influence our diagnostic outcomes. That's where rapid on-site evaluation comes into play. Rapid on-site evaluation helps us verify the quality of the specimen right at the point of the collection, ensuring that we have a viable sample before proceeding with more complex molecular testings like immunohistochemistry and next-generation sequencing. And now, explorative techniques are applied in our lab, discussing with specific challenges. And we have a lot of types of cytology specimens, and most of them are suitable for molecular tests. For example, the common cytological preparations, including cell block, advantage of resembling surgical pathology, and we don't need any validation for this because most of the tests are already validated for FFPE blocks. But of course, it has limitations, and the most important limitation is DNA fragmentation because of the formaldehyde fixations. And when we look to the direct smear, liquid-based light, and cytospin, we have a high-quality DNA, RNA, and if we were performing fluorescent FISH, we can see intact whole cells. But of course, we have to remove cover slip, and of course, we have to sacrifice our slides. But now we are lucky because we can compensate it by digital scanning. And for the liquid-based slides, some fixative contains formaldehyde, and it may cause DNA fragmentation or cross-linking. But don't forget, we are not using them a lot, but we can use cell pellets or supernatant of cytological specimens too. Okay, let's explore the intricate process of molecular cytopathology. Starting from microscopic examination of our slides, our initial step focuses on accurately identifying and isolating the neoplastic cells while diligently avoiding any contamination, which is paramount for maintaining the integrity of our sample. Once our preparation is complete, we embark on the manual dissection of this cytological specimen. And in situations demanding high precision, we may employ laser microdissections. And these advanced techniques ensure that the precise extraction of nucleic acids enhancing the accuracy of our subsequent analysis. As we progress to analyzing the extracted DNA or RNA, we face a decision on the sequencing approach, whether to adopt a hybrid capture or an amplicon-based method. I know that most of the lab just have amplicon-based or hybrid capture-based, but the ideal is to have both of them and to use which one is best for the test. And for example, each technique has a unique advantages. Amplicon sequencing offers a quickness and simplicity and ideal for targeting specific oncogene regions and capable of detecting mutation even at low allele frequency. And it's crucial for identifying the subcolonal population in small or mixed samples. Conversely, hybrid capture methods constructing a library through hybridization and suited for more extensive examination of gene regions. And of course, it takes time consuming, it's more complex, but the exhausting comprehensive genetic profiling. But now technology getting improving, and therefore most of the problems getting solved for the hybrid capture methods too. And we have to make our decisions hinged on the specific clinical biomarkers we aim to pinpoint, and this tailored approach helps us to derive the most clinically pertinent information, ensuring the optimal patient management. And this table shows everything that we need to know for better understand and critical elements for testing in cytology. First, we have our basic terminology and definitions. Analytic threshold refers the minimal input required for successful testing, which is essential to ensure the assay sensitivity and precision. And the lowest observable adverse effect level, LAOD, is a crucial metric here, as it tells us the lowest frequency of mutant alleles that can be consistently detected. And pure analytics involves the collection, processing, and handling of specimen, underscoring the foundational work that goes into preparing samples for analysis. And tumor fraction represents the percentage of tumor cells in a sample. This is pivotal because the proportion of tumor DNA influences the likelihood of detecting mutations. And when we come to the input DNA and RNA, is about the minimum amount of genetic material needed to achieve reliable results. And when the tumor fraction is above 20%, a reliable NGS readout is expected. However, if it's below 20%, alternative strategies like high sensitivity single target mutation analysis or NGS with enriched tumor cells through methods like laser microdissections are recommended. And another advanced technique involves using molecular barcodes to enhance analytic sensitivity and specificity, as we are using in the amplicon-based sequencing. And of course, we talk about the pre-analytic is the most important thing for obtaining a high-quality RNA, DNA, and of course, the specimen. Rapid on-site evaluation plays a pivotal role. And especially for the solid lesions, we can able to use rapid on-site evaluations, but don't forget, it does not recommend it for cysts unless they have a solid component. Okay, rapid on-site evaluations enables immediate and real-time cytopathologic evaluation. Additionally, preliminary diagnostic information can be given, and the specimen can be appropriately triaged for potential ancillary tests like flow cytometry, microbiologic studies, molecular studies, and immunohistochemical studies. Procured material can be evaluated by Romanowski stain preparations such as DivQuik stain. We are using DivQuik in our lab, or by a rapid Papa Nicolau stain. But the most important thing, when you are using DivQuik slides, you should be allowed dried completely before staining. Because if it's not dry completely, the images can be wet or dense mucus can cause pale staining. And another important thing is that to look to the blood very carefully, and there's a special name for this, macroscopic on-site evaluation MOS. As you can see, we can see clots here, but when we look closely, we can see the whitish particles in here. And if we are going to take them in a separate fixative for the cell block, you can obtain a high tumoral area. And for the on-site evaluation, if you can see this area in the smear slide, you can able to see if it's a tumor or not. And there are another examples in here. You can see there are whitish small particles when you look closely. And of course, rapid on-site evaluation increases diagnostic yield. However, it needs a cytopathologist and it takes cost and time and for the staining and interpretation. As we talk about that, macroscopic on-site evaluation recently introduced as an alternative to ROSE, and the literature showed high accuracy for the use in the pathologic diagnosis. If you don't have time or enough cytopathologists or cytopathologists or pathologists for performing roles, you can teach your technician to make MOS. And we evaluated the efficacy of the MOS in terms of tissue acquisition and diagnostic accuracy for the pancreatic lesions. MOS was effective for complementing EUS, FNA, FNB, ensuring the adequate material with a minimum number of needle passes, providing a critical high diagnostic accuracy. And therefore, MOS seems to be a viable alternative to ROSE in select clinical situations. And let's look how can we perform rapid on-site evaluation. Deep quick stain, you can see is preparing the slides. The most important thing is that we are preparing both air dried for deep quick and alcohol fixed slides for pop stain. And for the deep quick, you see that slides should be allowed to dry completely before staining. And smears prepared from the path can be alcohol fixed immediately and later stained with the Papanocula stain. Those are the key features. And to stain with the deep quick, the air dried slides are typically stained as follows: 10 seconds in fixative, 15 to 20 seconds in xanthan dye, and 20 or 25 seconds in thiazine dye, followed by a rinse in tap water. And this can be performed rapidly in the operating room. And if the cytopathologist determines that the sample is inadequate, then the physicians performing the procedure can modify the FNA technique or can change or can able to take FNB. And if he confirms that adequate diagnostic materials was obtained, then additional specimen collection can be performed during the procedure for ancillary studies like flow cytometry or immunohistochemistry or molecular tests. And it's important to point out the molecular testing success on FNA sample is directly dependent on the specimen adequacy. It should be noted the specimen adequacy is one of the advantages of the ROSE. But of course, it has disadvantages. We already talked about that. It needs time, it needs experience, on-site cytopathologists, and it needs extra time from cytopathologists, financial undercompensation of pathologist time, and need for optimal staining quality. And therefore, ROSE is not always warranted. Okay. When we are using from molecular tests. And now we are going to talk about molecular analysis in cystic pancreatic lesions. Okay, now let's focus on particularly on the pancreatic lesions, and which are crucial for early detection and intervention strategies. Dr. Atsay explained this beautifully in his lecture in this morning. Pancreatic cystic lesions are broadly classified into mucinous and non-mucinous neoplastic cysts, along with the benign non-neoplastic lesions. Understanding these categories helps is in identifying potential precursors to invasive pancreatic cancers. Mucinous cysts like IPMN and mucinous cystic neoplasms are especially significant as they are directly linked to cancer progression. On the other hand, non-mucinous neoplastic cysts, though less likely to transform malignantly, and still pose a risk and require vigilant monitoring. Furthermore, we will explore the molecular landscape of these lesions, and each type of pancreatic cystic lesions harbors specific molecular changes that not only help in classifying these lesions, but also in predicting their likelihood of becoming cancerous. And okay, these tables explain all of these genetic alterations very well. And these lesions are not only diverse in their histology, but also in their genetic underpinnings, and which can significantly influence both diagnostics and therapeutic approaches. Starting with intraductal papillary mucinous neoplasms, these are primarily characterized by mutation in KRAS and GNAS, and which are found in over 95% of these cases. Interestingly, the presence of this mutation does not necessarily correlate with the degree of the dysplasia, highlighting the complexity of their development. Additional mutations in the TP53, SMAD4, and various mTOR pathway genes are often associated with advanced stage of these neoplasms, marking them as the key indicators of progression to invasive disease. Now, moving to the mucinous cystic neoplasms, they share similarities with IPMN, such as KRAS mutations and the presence of RNF43 alterations. However, unlike IPMNs, GNAS mutations are rarely observed in MCNs. And this distinct molecular profiles helps in differentiating between these two types of mucinous cysts. And intraductal oncocystic papillary neoplasms, or IOPN, stand out their unique genetic alterations, predominantly involving rearrangements in PRKACA and PRKACB. And these alterations are not typically seen in other types of pancreatic cysts, suggesting a distinct pathogenic pathway for IOPN. And when we come to the intraductal tubulary papillary neoplasms, are notable of their absence of the common mutations found in IPMN and pancreatic ductal adenocarcinoma. Instead, they exhibit mutations in various chromatin remodeling genes and PI3 kinase pathway genes, suggesting a different trajectory in their tumorigenesis. And when we look to the serous cyst adenoma, are generally benign and rare, characterized by alterations in the VHL gene, which are pivotal in their pathogenesis, but are rarely lead to the malignancy. And this sets them apart in the spectrum of pancreatic cystic lesions. And when we look to the solid pseudopapillary neoplasms, are predominantly found young women and are defined by the mutation of the CTNNB1 and leading to abnormal accumulation of beta-catenin in immunohistochemistry. This specific molecular signature is crucial for diagnosis and does not overlap with the more common pancreatic neoplasm. Lastly, cystic neuroendocrine tumors exhibit a variety of mutations, including MEN1 and alterations in the mTOR pathway, reflecting their complex biological behavior and potential for targeted therapy based on their molecular profile. In summary, Understanding in this diverse molecular landscape not only aids in precise diagnostic categorization, but also informs targeted therapeutic strategies. And let's look some examples of that. Pseudocysts often arising in the wake of acute pancreatitis, presence without an epithelial lining, embodying collections of necrotic material encased in a thick inflammatory fibrous capsule. And the cytology of pseudocysts is characterized by a high amylase level and a very low CA level with no epithelial cells, but an array of inflammatory cells and other debris. The sets of the stage for distinguishing these from more complex neoplastic lesions. And when we turn to our attention to serous cyst adenoma, typical for low CEA levels and amylase levels, and exhibits a cellular landscape of non-mucinous cuboidal cells with a clear cytoplasm due to glucogen accumulation and have a VHL mutations. And when we look to the lymphoepithelial cells, CAA level can increase, but amylase levels are low, and we don't have any specific genetic mutations. And then look to the MCNs, the CAA amylase levels can be varying, but we have KRAS mutations, and we can see SMAD4, P53, and P63 in the high-grade lesions. Okay, let's explore the use of molecular tests in solid tumors, some of which are associated with specific gene mutation through immunohistochemical studies, while others guide therapeutic intervention. Let's also briefly discuss some of the immunohistochemical assays we routinely use. SMAD4, also known as DPC4, is a crucial marker in the diagnosis of pancreatic ductal adenocarcinoma, and the loss of immunohistochemical staining for SMAD4 indicates a mutation in this gene, which is found about 50% of the PDAC cases. This loss leads to the absence of nuclear staining in the malignant cell, as you can see in the picture, and significant indicator of cancer progressions, especially noted in the high-grade intraepithelial neoplasia and certain types of intraductal papillary mucinous neoplasms. And the absence of SMAD4 staining in certain non-invasive conditions and in distal extrahepatic bile duct carcinogenesis suggests that its loss is a late event in the carcinogenic process, which may not always represent invasive carcinoma directly. And when we come to the P53, staining for the P53 protein provides insight into the mutational status of the TP53 gene, and an accumulation of P53 in the nucleus typically indicates a mutation. However, in pancreatic pathology, P53 staining is not solely indicative of invasive cancer, since it also appears in non-invasive high-grade lesions too. And we have two distinct staining patterns and P53 mutation, a strong diffuse nuclear staining, and a complete absence of staining known as a null pattern. This contrasts with the wild-type staining pattern, which is pale and patchy, helping differentiate it between mutated or non-mutated cells. And besides these assays, where else do we routinely use immunohistochemistry in our practice? As Dr. Asay mentioned in his lecture, we can classify undifferentiated tumors as shown in the table. Some of them are immunogenic, and MSI high group is more responsive to the immunotherapy, while the metaplastic and rhabdoid types are more aggressive, and the rhabdoid types are associated with the SMARC family. And SMARC family actually comprise the components of BAF complex, having a lot of here SMARCA2, 4, R1, D1, and we are all familiar with the ANA1, which is related with SMARC-B1, while the stains for BRM and BRG1 are associated with the SMARCA2 and SMARCA4 alterations respectively. We know SMARCA4 from thoracic tumors, but it's crucial to remember that when we see a tumor with rhabdoid morphology, conducting immunohistochemical studies linked to these gene alteration and can aid to identifiable targetable alteration, because BAF complex related with BRCA1. And we discussed rhabdoid tumors associated with SMARC family. What about metaplastic one? Essentially, this group resembles the basal-like category and is not yet included in the guidelines. However, its immunohistochemical, morphological, and molecular characteristics share striking similarities with those of metaplastic carcinoma of the breast. In our unpublished study, presented only a poster at the USCAP, we identified this unique group with sharing the basal-like features, as I told, metaplastic carcinoma, and they have ARID1A mutation, 30% of the cases. And in both our cases and those from the TCGA database, we observed that ARID1A mutations, metaplastic carcinoma frequently exhibit a different histological images like megavacuolated and cribriform pattern or basaloid and squamate non-glandular nests with pavimenting pattern. Why this is important? Because ARID1A may soon have a targeted therapy. And when we look to the targeted therapies, because of the pancreatic cancer has low survival rates and high resistance to chemotherapy, we have just standard regimes like FOLFIRINOX and gemcitabine. And now we have emerging molecular tests and targeted treatment options. And mutations in genes like KRAS and TP53 have long been markers of the severity of pancreatic cancer. These mutations not only define the aggressiveness of the diseases, but also open new avenues for targeted therapeutic options. And let's look of them. This is a new paper. As you can see, critically tumor mutational burden, KRAS G12C, and DNA damage repair gene mutations stand out as significant. And there are a lot of alterations in here. We talk about ARID1A mutation, and maybe in the soon EZH2 inhibitors may be a alteration for treatments. And in this figure shows actionable molecular targets in color coded sections, and corresponding therapeutic agents are listed outside respective sections. And before implementing comprehensive genomic profiling for PDAC in our institute, we are focused on studies on homolog recombination for DNA damage repair genes and RNA-based studies for identifying gene fusions and KRAS alterations. And notably, our findings reveal KRAS mutations in a high percentage of cytologic samples compared to the biopsies and resections. And this discrepancy highlights the critical importance of choosing the appropriate sample types for molecular pathology tests in PDAC. And KRAS G12D mutation, identified as the most frequent alteration in pancreatic cancer, underscore its significance not only in our study but also broadly in the field. We are optimistic as targeted therapies for KRAS G12D and may soon become available, offering new avenues for treatment in pancreatic cancer. And summary, molecular testings utilized for both cystic and solid pancreatic lesions, and enhancing precision on classifying benign, premalignant, and malignant form. But we need high-quality nucleic acids from sample, and procedure like rapid on-site evaluation being useful for sample collection and nucleic acid quality. And for the cystic lesions, biochemical results, molecular studies, and morphology collectively aid in accurate diagnosis. And for the solid lesions, increasing availability of targetable mutations necessitates for comprehensive genomic profiling to ensure sufficient sample quality for routine integrations. Thank you for listening to me.